Good morning all. I'm Devam Sheth. I'm currently working at Northside Hospital, Youngstown, Ohio. Soon to graduate, and I couldn't wait to start my own practice. So this place has been great, and this is my second year here, and I would like to thank SMA for all these wonderful arrangements. Without any further delay, I would like to start with our first case, which is dermatologic mimicry. I'm not giving up front as to what the condition is, just to keep an element of suspense. I do not have any financial disclosures for this presentation. Objectives would be to learn about certain skin reactions caused by certain medications, in particular vancomycin, differential diagnosis as to what could mimic such conditions, and what is the treatment and prognosis of such conditions. So the case is about a 30-year-old African-American female who has long-standing history of lupus, was admitted with fever, chills, abdominal pain, and altered mental status for a few days. Physical exam revealed severe diffuse abdominal tenderness, altered sensorium, along with chronic lupus skin rash on her hands and feet. Family history is significant for a maternal uncle who died from Stevens-Johnson syndrome, etiology not known. She had a pretty long past medical history, surgical history, and family history, but I'm just keeping the pertinent details so as to not to confuse the case. And her current medications include prednisone, mycophenolate, hydroxychloroquine, levetiracetam, pantoprazole, and oxycodone for pain. Most of these medications are for her lupus, and the levetiracetam is for the lupus seizures that she had many years ago. On admission, her labs were unremarkable except for mild anemia secondary to her lupus. So at the time of presentation, she mimicked as if she was having some sort of sepsis. So given her immunocompromised state, she was started on broad-spectrum antibiotic coverage that included vancomycin and cefepime. She was appropriately pre-medicated with diphenhydramine and ranitidine for a presumed vancomycin infusion-related reaction in the past. Now, all of us know that vancomycin is notorious for the Redmond reaction that causes flushing of skin and people turn red. So she came to the hospital just by herself, and because of her altered mental status, she was not able to tell us clearly as to what the reaction was in the past, but from the description it sounded like Redmond reaction, and so we treated her appropriately. Usually vancomycin is given over 2 to 4 hours, 1 gram of vancomycin, and we, presuming that this was a Redmond reaction, we pre-medicated her and gave it to her even very slowly over a period of 8 hours. However, 2 days later, she developed a pruritic 2 by 2 centimeter maculopapular fluid-filled cystic lesion on her left thigh that did not fit any particular clinical diagnosis. Another such lesion developed the next day, after which vancomycin was thought to be the culprit and it was discontinued. This is this is a picture of her left thigh. Can I have a pointer?
Yes, please.
So these are some old lesions that we discovered, which we didn't get a chance to see when she came to the hospital. This is the new lesion that developed. As you can see, it's slightly raised, about 1 to 2 millimeters thick, 2 by 2 centimeters in diameter, fluid-filled or surrounded by a base of erythema. And 2 days later, after the dressing was uncovered, the cyst had burst open and there was a raw ulcer, very superficial raw ulcer beneath it. So the differential diagnosis at this point includes erythema multiforme, Stevens-Johnson syndrome or toxic epidermal necrolysis given a positive family history, and that is what scares us the most, bullous pemphigoid, and fixed drug eruption. So starting with erythema multiforme, this is what a true erythema multiforme looks like. There are 3 layers, as you can see, distinct 3 layers, as compared to the 2 layers that this patient had. And it's in 90% of the cases, it is associated with HSV infection. Patient would have past history, or patient would have current symptoms of HSV infection, which she didn't have. Moving on to Stevens-Johnson syndrome, there is a very strong association with HLA-B150, which is seen in Oriental population. And so in Oriental countries, a lot of physicians would check HLA-B150 before starting certain medications that precipitate Stevens-Johnson syndrome. This is extensive Stevens-Johnson syndrome with generalized eruptions of lesions that initially had target-like appearance, and then they merge together, become confluent, and lead to a full-blown Steven Johnson. Like picture if the total body area involved is less than 30%, it's Steven Johnson. If it's more, then we call it toxic epidermal necrolysis, 10. And one differentiating feature of Steven Johnson is that in about 90-95% of cases, it will include mucosa or a mucous membrane anywhere, whether it's your oral cavity or within your GI system. Somewhere you will have signs of mucositis, which this patient did not have. She just had solitary 1 or 2 lesions. These are the mucosal changes seen in SJS syndrome. This is a picture of bullous pemphigoid. Bullous pemphigoid is usually multiple tense bullae that appear on the skin with eroded blisters, but they heal without scarring. That is very typical of bullous pemphigoid. She had some lesions from the past, but there was no signs of scarring. So bullous pemphigoid was a differential, but the bullae were not typical of bullous pemphigoid. They were very flat, very superficial. When we biopsy these bullous pemphigoid lesions, the histology reveals a subepidermal blister with dermal infiltrate of eosinophils, neutrophils, and lymphocytes. And direct immunofluorescence of these lesions would show linear IgG or linear C3 staining along the basement membrane zone, which is absent in all other conditions. And the diagnosis of bullous pemphigoid can be confirmed by ELISA assay demonstrating circulating autoantibodies against the pemphigoid antigens, which are BP180, NC16A domain, and BP230. So we ended up getting a biopsy of the lesion, and there was no such staining, there was no immunofluorescence. So we ruled out bullous pemphigoid as well. And so we are finally left with fixed drug eruption. Acute fixed drug eruption usually presents with a single dusky red or violaceous plaques that resolve, leaving post-inflammatory hyperpigmentation. The very first picture that I showed had some oval lesions, and that resembled the old lesions. A typical fixed drug eruption is usually flat. It's not fluid-filled or cystic. An oval lesion occurring at similar sites where the previous lesions had occurred, and as we could see, the cystic lesion that was new was in the same region where we found those old pigmented spots. This is a case where patient had a sulfonamide antibiotic, and then she had this blister and that eroded in the center. As you can see, the blister is having 2 layers surrounded by a base of erythema, and it's pretty much raw and uneven. So medications that can cause fixed drug eruption include a lot of antibiotics, penicillins, tetracyclines, sulfonamides, quinolones, dapsone, NSAIDs, Tylenol, barbiturates, antimalarials, phenolphthalein, and gold salts. We reviewed literature, and we could not find any evidence to support that vancomycin can be one of the cause. Cefepime can be a cause of fixed drug eruption, but on the very first day when she had the first blister, we stopped cefepime and we continued vancomycin, and then she still had the lesion. So that brought us to the conclusion that vancomycin is the culprit. So a biopsy is warranted in the following circumstances. If you have an experienced dermatologist on the case, he would pick up such conditions without any biopsy. But coming from a community hospital where we do not have that privilege, we are bound using the help of our pathologist to come to a conclusion. Biopsy is indicated if the clinical presentation is unusual, such as generalized or bullous FDE. So our patient had bullous FDE. That raises the suspicion of severe drug reaction. If your patient has systemic symptoms such as fever, malaise, which our patient had, but she came in with those symptoms, so we cannot blame it on to the medication or the condition. And when the diagnosis is uncertain, such as negative medication history, patient did not have any new medication, in spite of that, patient developed such lesion, then we need to biopsy the lesion to find out the cause and see what we can do for the patient. Histologic findings that support the diagnosis of FTE include hydropic degeneration of the basal layer, pigmentary incontinence, single necrotic keratinocytes in the upper layers of the epidermis, and a dermal inflammatory infiltrate predominantly composed of just lymphocytes as compared to all 3 types as seen in bullous, pemphigoid bullous. In generalized bullous FTE, the examination of a biopsy taken from the blister area reveals full thickness necrosis of the epidermis without any pigmentary incontinence, and this is exactly what we found from one of the biopsy lesions that we did. And whenever we have to do a biopsy of such lesion, the biopsy has to include half of the ulcerated lesion and the rash, and half has to be the normal skin that would serve as a control. So treatment is just symptomatic. Discontinuing and avoiding the offending drug is the most important aspect of FTE. Symptomatic treatment of acute eruption may include medium to high potency topical corticosteroids group 1 to 3 and systemic antihistamines. She was on prednisone before. Given her acute illness, she was bumped up. She was given stress dose of steroids, and even then she developed this reaction, so there was nothing much we could do except for stopping the medication. So we stopped vancomycin, and within a day or so her lesion started resolving. This is a fixed drug eruption resembling erythema multiforme. This, as you can see, there is dermatomal distribution mimicking herpes infection. This patient's herpes titers were tested and they were negative, and so a dermatologist was called upon, and on review of medications, they identified the culprit drug. They stopped the medication. The lesions disappeared. But how to diagnose when the lesions have disappeared? So they gave the drug again just to see if that was the case, and the lesions reappeared. And that is how we get to know more about this condition, fixed drug eruption. So coming back to our patient, this was just one of her issues. We didn't actually know why was the reason she got so sick, and when the cultures came back, all were negative. We didn't find the source of infection. So after 5-6 days of antibiotics, everything was stopped. And then one of the family members came to us and told us that she was from nursing home, and somehow her steroids were stopped at the nursing home. So she went into adrenal insufficiency, and this is how adrenal insufficiency can present. Patient might not have all the classic symptoms of adrenal insufficiency, such as hypotension and your electrolyte imbalances, but they can mimic severe sepsis. And even if we know that this is adrenal insufficiency, we should have broad spectrum coverage to begin with, just to be on the safer side. So after she came to the hospital, she received stress dose of steroids, and boom, she got better in a couple of days. So that's pretty much about the dermatologic mimics that we have from the antibiotics that we use. I'll take a few questions if there are
Let's
any.
stop at this point and take a question. He's going to do his presentation next. I will say, as a plastic surgeon, I see a lot of our dermatology colleagues will send patients with a variety of skin lesions that can look like any number of things. I assume if they send them to me that they want a significant biopsy, and so the issue becomes, these are complex patients a lot of times. And if you look with your patient in the very beginning, they have she's taking a lot of medications.
A lot of medications.
But the list, if you go back a couple of slides and put your list back up with the common medications, can you do that? Can you go backwards about 3 or 4 slides? That list right there, it's your usual antibiotic culprits, Tylenol, the NSAIDs, and then a few others down there. And those tend to be the ones that we see. But I'm frequently biopsying things in the office that are turn out to be non-surgical, but I'm happy to do a nice biopsy. Any questions? Okay. Well, thank you for doing Dr. Rao's presentation. And let's get your presentation queued up here. Let's see if we can do that. Mm-hmm. Jim, do we have control of this one? I'm not sure which way they. There we go. Okay. Let's see, maybe it's right here. The Saturday present. Nope, not there. Do we have any dermatologists in the group? this morning? Dermatology can be pretty complex. You know, we think of it as, you know, smaller lesions and things, but dermatology can be a fairly complex specialty, and I always appreciate my colleagues. I know when I'm getting a referral from a dermatologist, that's almost always a surgical case, and I take them very seriously. We give them priority, and there's almost always, they're pretty good. They almost always have biopsied something or have a pretty good clue about what it is. They have some pretty interesting things, and depending on your perspective and what you do exactly, the dermatologic problems can be pretty significant.
Right.
Yeah. Now, getting them to come to the hospital and do a consult is a different thing.
Oh, in my 3 years of career, I've never seen a dermatologist come to the hospital. Mm-hmm. If anything, we call them, and as a courtesy, they would ask us to email them some pictures, and they would offer a phone consultation. Mm-hmm. But that's the best we can get, and I agree with that kind of service. There's no point for them leaving their practice and driving all the way like 30 minutes back and forth, and then spending 1 hour over a consultation that could be just addressed over phone in like 5 minutes. Yeah.
Okay, well, we'll move forward with your presentation and go ahead and.
All right, so I guess there's no need for me introducing myself again. This case I have is an angiosarcoma of tongue, which is an extremely rare tumor. Probably if we have any pathologist in the audience, he would be able to back me up. Very, very rare to find. And this case is quite unique, and I'll tell you in a couple of few slides as to why this was so unique case. Again, I do not have any financial or any other disclosures, no conflicts of interest. Objectives of this presentation would be to understand what is angiosarcoma, what is the standard of care for such patients, and what is the prognosis of this cancer. The case is a 92-year-old Caucasian female with past medical history of atrial fibrillation, CHF, who presents with a left-sided tongue mass that was slowly enlarging over past 6 months and causing her some discomfort. So in a 92-year-old female, whenever we hear about any malignancy, the first thought is, okay, we are not going to be very aggressive. The first thing we want to do is just to discuss with the patient as to how far she wants us to go with her care, and we take it from there rather than what the standard of care would be for such cancers. The risk factors for her were denture use for many years, but no recent trauma, radiation exposure, or smoking history. Now, cancers of oral cavity are notorious in people who have been using dentures for a lot of time. The dentures by themselves are not a risk factor, but because of the chronic trauma and erosions they cause, they are notorious for causing squamous carcinomas. Angiosarcoma is not typically caused by any of such conditions, but we just have a handful of case reports over past 5 to 6 decades to comment on anything. So we tried to narrow down if we could find any potential cause, but there was none in her case. Oral exam revealed a soft, warty mass about 2 centimeters in diameter on the left lateral margin of the tongue. It was like a small strawberry hanging out from her tongue. On palpation of lymph nodes, no lymphadenopathy was felt in her cervical, axillary, or supraclavicular region. A PET-CT was done to see the extent of spread, and it showed a mass in the lateral left mobile tongue with an enlarged enhancing lymph node in the adjacent left submandibular space with maximum intensity of 10.7 and 3.5 respectively, which is pretty high, and it tells you that the lesion is active. It's not something benign. So the patient was referred to an ENT surgeon, and a biopsy of the mass was done that revealed diffuse high-grade squamous dysplasia with focal in situ carcinoma, along with focal areas of proliferation of malignant appearing spindle cells. Immunostaining was performed with S100, Melon A, and SMA, which were negative. The specimen showed diffuse positivity to vimentin and focal positivity to CD31 and CD34, thus supporting the diagnosis of high-grade angiosarcoma. The angiosarcomas have two components. One is the smooth muscle cell that has to be present in the tumor, and the other component is the high vascularity, high vascular bed that we find in the tumor, and that leads to the diagnosis of angiosarcoma. I'll show a couple of slides with all the different stains. This is how a typical H&E slide would look. So this is the normal mucosa of the tongue, and there was some squamous dysplasia here, and all this area, all this big funky looking cells are the tumor cells that have infiltrated the normal mucosa. Same stain on a higher slide. As you can see, there are a lot of cells with multiple nuclei, giant cells. These are some blood vessels lined with, again, the same giant cells. And as you can see, in the specimen, there are a lot of blood vessels, these open spaces. But that still does not confirm the diagnosis of angiosarcoma. We need to have special stains to see whether the vascular component, the smooth muscle component, is malignant or is it just the normal component. This is an S100 stain that rules out melanoma and neural tissue. If there were any melanoma or neural tissue, it would stain dark brown. But as you can see, all the cells are stained pretty light, and so we ruled out melanoma and neural tissue. This is a pankeratin stain. It usually stains glands and picks up adenocarcinomas. This outlines the normal mucosa of the tongue, and this is all the tumor cells. As you can see, again, they are not stained, so the tumor is definitely not an adenocarcinoma from a secondary. LCA stain is leukocyte common antigen stain. It picks up lymphomas and other stuff. Again, same histologic pattern, normal mucosa and no staining of the tumor cells, ruling out any lymphomas. CD31, this stain typically stains the endothelial cells. So as you can see, all the blood vessels are stained quite positive because they do have endothelial cells. But in between the blood vessels, there are this other small cells that are stained by the CD31 stain, and that leads to the suspicion of having a vascular component in the tumor tissue. This is a vimentin stain, most commonly used to pick up sarcomas. It stains your smooth muscle cells, and as you can see, the normal tongue mucosa is not stained, but rest of the entire area is stained by vimentin, pretty strongly positive, giving us a component of sarcoma in the tumor bed. So an angiosarcoma is a tumor originating in the vessels of blood or lymphatics, typically occurring in the face and scalp region, which is your exterior but never seen in oral cavity. It tends to occur more frequently in Caucasians, males, and in sixth decade of life. Comprises about 15% of head and neck sarcomas. And the 5-year survival rate for angiosarcomas of head and neck region is really bad. It's less than 40%. Tumors arising from the tongue tend to be more aggressive with extremely high 2-year mortality, and depending on the size and disease extent. This lady had a 2-centimeter lesion along with a positive node. So that tells us that she already has metastasis, and the metastasis, we were able to just see the metastasis in the tongue, but there are micromets all over. So we cannot say for sure as to how far has the disease extended, especially when you have a vascular component in the tumor. So as per the NCCN guidelines and the staging, she was stage 3 with a T1, N1, and M0. Based on the limited data, there was just one case series comprising of about 6-7 patients done by Stanford, and based on that case series, the standard of care was determined to be complete surgical resection with wide margins along with radiation. So we are talking about a major commando dissection in a 92-year-old lady, which of course she declined, and we are not going to offer her that. The role of neoadjuvant chemotherapy remains unclear at this point, but it has been known for years that chemotherapy containing platinum-based compounds is radiosensitizing, and so if we are not opting for surgery, it won't be a bad idea to give 1 or 2 rounds of chemotherapy and making the tumor radiation sensitive. And chemotherapy can definitely be considered for younger patients who have aggressive features of the tumor. Due to her advanced age and preference, she just received radiation. She had some misconceptions about chemotherapy, and she didn't want to go through all the trouble, and we completely agree with that. So she received a total radiation dose of 66 GY spread over 8 weeks with a daily dose of 200 CGY. Giving radiation to oral cavity and the neck region is very tricky. There are a lot of important structures around, and you do not want any fibrosis around the major vessels in your neck region. So complex area had to be covered, and our radiation oncologist did a pretty good job at covering both her mass and the lymph node that she had that came back positive on the PET scan. She responded very well to the treatment, and the tumor shrunk, just leaving a small 3 or 4 millimeter remnant. After 1 year follow-up, she had the same remnant lesion without any evidence of metastatic disease. The lymph node calmed down. It didn't light up again on a repeat PET scan that was done after a year. The problems that we usually see in patients who get radiation to their oral cavity is a lot of mucositis and loss of salivation. So these patients are very malnourished. They are not able to eat or drink anything because of the pain. So this patient, for the first 2 to 3 months, had a PEG tube, and we took care of her nutrition, and she did remarkably well. Conclusion of this case report is that this case demonstrates the possibility of using just sole radiation therapy for patients who are not good surgical candidates or opt against surgical intervention with this rapidly advancing malignancy. Further studies need to be done, and given the rarity of this case, we cannot generalize it to all other patients, but this case can serve as a further guideline for the patients who by preference opt not to undergo the massive dissection that is the standard of care for such cancers. And its application to angiosarcomas arising at other sites, which we commonly see on their face or on their extremities, trials could be done to see if radiation along with chemotherapy gives us the same results rather than surgical excision of such big lesions, or maybe sometimes we end up amputating their limbs. And that's the end of my discussion, and I'll take some questions.
Very good. Any questions? I will point out something I've noticed, and that maybe you want to speak to just briefly, is the number of different stains that have come about for the various tissues. If you go back a few slides, and where are your slides there, and look at the headings here. I've noticed our pathologists and have on these especially complex cases use much more staining techniques to differentiate the sources, and sometimes it's not so quick anymore.
Right.
Some have to be sent off. Some are immuno stains.
Right.
They have certain labs across the country, but flip through those. You got pan-keratin, S100, Vimentin, a variety of them that through these cascades sort out the exactly what you're dealing with.
Correct.
Because ordinarily you'd think this would be a squamous cell.
Right, right.
And it's not. So.
Correct.
Okay, well, let's give Dr. Seth a hand, and especially for doing 2 presentations. And if